Hello and welcome everyone to the ESCAPE podcast. The ESCAPE project, funded through Horizon 2020, is a research and innovation project that seeks to redefine how we care for our elderly loved ones. Our team is dedicated to enhancing the quality of life for those facing complex health challenges, bridging the gap between physical and mental health care. In this episode, we'll dive into ESCAPE's approach, methodologies, and progress to date. I'm Rochelle, and I lead on ESCAPE's communication, dissemination, and knowledge transfer activities. And I'm joined here by my colleagues Suzanne, Svetlana, Olivier, Dagmar, Christoph, and Martin, and I'll let them introduce themselves.
My name is Suzanne Peterson, and I'm a psychologist working in the field of cardiology primarily, and I'm the coordinator of ESCAPE.
Perfect, thank you. And Christoph?
My name is Christoph Hermann-Lingen. I'm the director of the Department of Psychosomatic Medicine and Psychotherapy at the University of Göttingen Medical Center in Germany. Our main task in ESCAPE is to lead the integrated care trial where we are testing the intervention.
Okay. Svetlana?
My name is Svetlana Kanesova. I'm a project manager in Eurocarers, which is one of the partner organizations in the ESCAPE project. Eurocarers is an umbrella organization that brings together carers organizations and relevant universities and research institutes from across Europe. Our network works to ensure that care is valued and unpaid care is recognized as central to the sustainability of health and long-term care systems. In the ESCAPE project, I work on knowledge transfer and dissemination activities.
My name is Olivier Jacquemin. I'm working for Eurocarers. I'm in charge of communications of all the projects that Eurocarers is involved in. I initiated the awareness campaign, European Carers Day, 3 or 4 years ago, and I'm still managing that campaign every year. As far as ESCAPE is concerned, I'm mainly working around dissemination.
Dagmar?
Hello, everyone. My name is Dagmar Lühmann. I'm a trained physician, and I work at the Department of General Practice and Primary Care at the University Medical Center Hamburg-Eppendorf in Germany. So I hold the position as a research coordinator here, and my own research focuses a lot on multimorbidity. We do epidemiological studies, we do interventional studies, and I'm also a co-author of the German guideline for primary care to deal with multimorbid patients. And in ESCAPE, I'm responsible for intervention development together with Bea Herbeck-Belknap, who cannot unfortunately be here today.
Thank you. And last but not least, Martin?
Yeah, my name is Martin Denner. I'm the managing director of Berge Selbsthilfe, which is the umbrella organization of German patients organizations. And of course, we've got member organizations with cardiovascular disease also in our organization. And my role here in the ESCAPE project is to bring in the patient's perspective and to bring in the link to the patient's organization in the project.
Perfect. Thank you, everyone. So, Suzanne, could you briefly explain to us what the ESCAPE project is?
Sure. So with ESCAPE, we want to improve the care for patients with multimorbidity, but also their carers. As we know that both are challenged because of the impact of multiple diseases, and also because we don't everywhere in the world have integrated care. So we decided from the very beginning also to introduce the carers as they are important in this whole process. And the purpose of ESCAPE is to develop and evaluate the clinical effectiveness, cost effectiveness and cost utility of the integrated holistic biopsychosocial patient-centered intervention that is specifically targeted to the needs of elderly patients with multimorbidity, while also involving their carers. So that's kind of the first objective. And the second objective is to introduce and test quality indicators to assess the quality of healthcare for patients with multi-morbidity. And the third objective is to contribute to guidelines, obviously, depending on what comes out in terms of the results of the project.
So maybe a question, for anyone here is, for a patient and their carers, what's a normal situation for them when they enter, let's say, a sort of generic European healthcare setting? How are they dealing with their, multiple illnesses? How is their care supporting them? And then how is Escape trying to reevaluate that?
Okay, I would say the normal thing is, in most countries, patients have general practitioners, family physicians who provide long-term care and who try to oversee also the different specialist treatments that are required. But it's in most systems rather difficult for the patients and the carers to find the adequate specialist, to get treated in time. So there are sometimes long waiting lists. Also, there are community resources available that would help the patients a lot, but the person at the center, the general practitioner might not know about them, and it's not in their tasks to make connections and to give recommendations for patients to enter, for example, these community services. So the new thing in Escape is that there's a person, the care manager, who builds up a contact with the patient, who explores with patients and carers what the preferences and goals are, and then sets out to make the necessary connections to the different resources.
Yeah, I just also wanted to point out that the healthcare systems in Europe are very complex, and the digitalization of the treatment is changing them in a tremendous way. And especially elderly persons, multimorbid persons, they need a trustworthy support in these complex systems to navigate there. And therefore, the patient pathways have to be clarified. And we also need layman understandable information, especially barrier-free information. And therefore, it is important to have a bundle of measures, to have an intervention to fulfill all these supporting tasks. And therefore, I think the Escape project is very important for the patients in the future in the healthcare systems in Europe.
Perfect. So maybe a moment in case some of our listeners aren't so well versed. Could we get a definition of what is multimorbidity and maybe an example?
So in terms of multimorbidity, I just wanted to add, maybe it's not answer to what you were asking, but I think maybe it's important to say that usually when people talk about multimorbidity, it's at least two kind of diseases, let's say cardiovascular disease, and then maybe they have COPD. But I think what is unique about Escape is that we have chosen also to include mental health. And at least when I sometimes hear people talking about multimorbidity, they are not necessarily including the mental health issues. Although we know, let's say if you're just looking at patients with cardiovascular disease, if they have anxiety or depression, then we know they have worse quality of life, they have a greater risk of morbidity and mortality. And that's what I've just wanted to emphasize, the importance of that in Escape.
So I think an important element of Escape, and when you're on our website, if you're looking up anything about the project, we hear this phrase a lot called blended collaborative care. So I'd like to turn to Dagmar and get you to explain this concept to us and how this is used within Escape.
Okay, so I'll start with explaining what actually we understand with collaborative care, and I turn to the blended then afterwards. So by collaborative care, we understand an approach that sets out to support chronically ill patients within their living environment and within their healthcare context that they exist in. It's a team approach, and the team approach targets bridging the gaps of the different players that are actively involved in the care of these individual patients. And typically that is achieved by active follow-up by a non-physician care manager who supports patients, who, for example, educates them about their illnesses, imparts evidence-based treatment recommendations, discusses with the patients their treatment experiences and their current preferences and goals, supports changes in health behavior, monitors reactions to treatments, and also brings along suggestions from treating physicians how care could be adjusted. We hope this all will raise or will help to raise the quality of life of our patients. And the specialty about blended collaborative care is that these patients are not only suffering from different somatic illnesses, so bodily complaints, they also suffer from psychosocial distress. And we think this makes it even more important to bridge the different providers and establish a close contact to really support those patients.
So within this intervention, within this approach we're employing here, the care manager is very much situated, it's very much central to the implementation. So Dagmar, could you give us a few words about who are the care managers and maybe a little bit about what their day-to-day looks like in this approach?
So our care managers in the ESCAPE project are actually people who have some background in healthcare provision. So many of them are nurses, some are psychologists, with a bachelor degree. They discuss with the patients what their basic health goals are. So what would they like to achieve? So there's many patients having problems, for example, with mobility. Most of them in this very first talk say they would like to be more mobile, they would like to be more autonomous, do their own things, steering their lives. And then this also clarify to what degree carers should be involved. Is there an informal carers in the household who can support, who can do things, or who can even be present in the talks? And the next step, this information from patients, from GPs, is discussed in a clinical specialty team. This specialty team are doctors now. And among this group, the care management process is lined out. We define some minor goals, achievable goals. They involve the carer, discuss with the carer the health goals to be pursued, and then the care management process starts. And that involves, on average, telephone calls with the patients and the care manager, discussing how could the goals be achieved, where are problems, are there information needs that need to be covered, maybe other goals to be set, are there symptoms that are worrisome that should be cured, and that is more or less the process. So I think I should stop here the explanation, and you can rather ask questions what is of interest.
So I think maybe to do sort of a summary on this, we've got, our patients and our caregivers, and they're working with our care managers, and our care managers are then connecting their healthcare information with the specialist teams, which is a composition of all of our different types of specialties, and their GP, and making sure that process is simplified and easier for the patient and their carer. So I think a question people might ask, though, is why this sounds like something maybe the GP does. If you don't know the system that well, why is the GP not best suited to take that role?
Well, in most contexts, it's the GP just looks, well, they have the experience, they know the patients for a long time, but it's not, they're looking after the medical problems. They're not really, it's not their task to really go into, for example, social problems. It's also too much for them, actually, to regularly and proactively seek the contact to the patients and pursue small goals. It's more than a GP can give, what the care manager gives.
We've talked about kind of health goals and setting goals with the care managers. What does that look like for a patient, for example?
That may be very detailed. So I use the example about physical activity beforehand. So the overarching goal might be, I would like to be able to move more, move myself more, do more exercises, go outside the door and go shopping or something. That might be overarching goal. But if somebody has been confined maybe to bed, has a longer hospital stay, or a heart failure symptomatic with not being able to breathe fully, that is very difficult. And especially it's hard to reach. If you formulate such an overarching goal of, I want to be able to go shopping again, it might not be reachable within a time frame, and patients get frustrated. So what the care managers do is that they break down these overarching goals into very, very little steps. So maybe the first step might be to move around in a person's apartment again using a walker or something. Then practice that maybe for a week or two, giving feedback. How did it go? Was it too stressful, or did you manage well? If the person managed well, then maybe take the next goal, say, okay, accompanied by a carer, for example, step outside, go in your garden, and maybe do 10 minutes of walking around. And then again, collecting feedback after some time. How did it go? What can be improved? Or did you manage, or did you manage not? Why not? So that means goal setting and monitoring how the goals are reached or maybe not reached. That's one example from exercise, but also some patients might have goals concerning dietary problems, or maybe concern with sleeplessness or whatever. But what care managers do is, together with patients, break down the overarching goals into little manageable pieces and support them achieving those micro goals, as we call them.
And to my colleagues at Eurocares, within your expertise and your networks, is this also a priority for the carers and the organizations that represent them?
Yeah. From the perspective of carers, be they formal or informal family carers, the ESCAPE BCC blended collaborative care approach will have a very important impact on the well-being of both patients and the carers. Patient-centered care recognizes the vital role that the carers play in the health and well-being of elderly patients. healthcare providers will be encouraged to offer more comprehensive support and resources for carers, such as education, respite care, counseling, etc. Acknowledging the carers' needs and providing them with the tools to manage their responsibilities as carers will lead to improved care outcomes in general and will reduce the risk of carers' burnouts. Under BCC, the ESCAPE blended collaborative care approach, elderly patients and their carers will be actively involved in the decision-making processes regarding their healthcare. And this is kind of an empowerment which will lead to greater patient satisfactions and adherence to treatment plans as well. Involving the patients and their family carers in the care decisions will lead to a more holistic approach to healthcare. Considering not only the medical needs of the patients, but also the social and emotional well-being of both the patients, but also the carers. So ultimately, this approach will hopefully enhance the overall quality of life for both the elderly patients and their carers.
Okay, so we've been talking sort of, we're very specifically about the intervention here, but obviously, or within ESCAPE, we are doing this within the context of a clinical trial. So maybe I'll turn the floor over here to Christoph, and if you could give us a little bit of information about what is the clinical trial, why do we even need one?
Sure. Well, as you heard, it's a very exciting idea to provide that sort of care management to patients, and studies from the United States, mainly from the United States, have shown that it works for some groups of patients. But it has not been shown that such blended collaborative care works within the different European healthcare context at all. And it has not been shown to be really helpful for multimorbid patients. So why did we choose multimorbid patients? We think these patients are in particular need of someone who coordinates the care delivered by multiple different specialists. And these people are often, for medical reasons, unable to navigate the complex system, as we already heard. So multimorbidity is a very good starting point for testing such an intervention in Europe. And that's why Dagmar already mentioned we have that multi-professional and multidisciplinary specialist team that really oversees the whole process. The second thing is we chose one index disease, that's heart failure, which is very prevalent in elderly patients and is in most cases associated with other illnesses and with substantial emotional and psychosocial burden. So these people are really in need. We believe they need better help than they on average receive nowadays, but in order to demonstrate that it really works better than the fragmented care people usually receive, we need a study. And the study we're doing is what people call a comprehensive cohort study with an embedded randomized controlled trial. That's very complex. What we are actually doing is we are looking for patients who are multimorbid, who have heart failure, who are psychologically distressed, and who are interested in taking part in a research project. And in the first step, we look if the intervention we would like to offer really fits those patients' needs, whether they fulfill the so-called inclusion criteria. And we do that not only once, but twice in order to be sure that temporal problems haven't just resolved and people don't need any more help. We want to really address those people who have chronic problems. So if they are still sick and still psychologically distressed at 2 or 3 months after our initial assessment, we ask patients if they are interested in possibly participating in our clinical trial, which is a chance of 50% to receive the blended collaborative care intervention for some of the patients. The other 50% by chance just stay within the cohort and are observed for the next years in order to see how their illness develops. And the main thing we are interested in is how it develops in terms of what patients feel and what patients realize in their lives. And therefore, we chose health-related quality of life as our primary endpoint. So we cannot just measure one simple blood marker or one X-ray photo or so, because people have so different illnesses, and the most global and most patient-relevant endpoint is quality of life, and that's our primary target, to improve that.
And we're talking about quality of life measures. What are we looking at?
And that's more or less a philosophical question, because what is good life? That differs very much for different people, and it would be nice to dig more into the details here. But there are international standards how we define quality of life in clinical studies, and usually we ask the patient. Of course, we can also ask the carer, and we are actually asking the carers. But what we are asking is how well they feel and how able they are in their everyday life to perform their daily tasks in terms of physical ability, in terms of emotional ability and well-being, and in terms of social ability and connectedness. And we're using standardized questionnaires that are filled in by both the patients and the carers to summarize these dimensions, and we calculate indices where we can say, okay, quality of life has improved from 40 points to 60 points on a 100-point scale, for example.
Okay, and then maybe a few words on where is our clinical trial taking place? Where are the patients being recruited?
So we have partners with recruiting sites in Germany. That's 4 sites, in Denmark 3 sites, then 1 site in Lithuania, 1 in Hungary, 1 in Italy, and 1, of course, Ireland, with the site in Dublin.
So one thing that I think is really interesting, and Susanna touched on this, is the recruitment considerations. And we have to have some kind of mental health consideration, but of course we are working with patients that are 65 plus. I'm not sure if we mentioned that that's one of our criteria. So with patients who are elderly, is there an openness and a willingness to talk about their mental health challenges?
Well, I can answer to this. That really depends very much on the person. There are still many older patients who have been raised with the understanding that you never talk about emotional issues. And of course, some of the patients say, well, I get along, and usually I have to do everything on my own and I don't need help from anybody. But there are increasing numbers of cardiac patients who understand, also given the advances in psychocardiology, that's the research discipline studying the interconnectedness between the heart and the mind, that it's important to also talk about emotions and to get emotional support or social support when dealing with heart disease. So openness is increasing, but it's still a challenge to get people interested in taking up our suggestion and joining the trial. So that's something that's really needs some work of our recruiters to convince people that it could be helpful.
And I'd like to add that it also depends on the care managers, of course. As I already said, they have to be trustworthy persons in the eyes of the elderly people, and they have to be able to identify the patient's needs and the patient's preferences. And it's due to a good communication in this situation that it'll work.
Yeah, that's such a good point. It's a patient driven, or it's a person driven intervention. It's all through the care manager and those relationships. So yeah, absolutely. How has the appetite been for this? How have the patients been reacting?
We did a feasibility study, actually.
Sure.
So that was to test how the implementation of the intervention works. And 10 patients were treated. That was in spring, I think, last year or so. It was before the trial started. And the feedback from the patients was quite good. So there was, I think, Christoph, you probably have the figures better in your head than I have, but I think up to 80% of patients reached some of their micro goals. There were some dropouts even in the feasibility studies, but most of the patients actually reached some of their micro goals, maybe not all of them. The intervention was just short. It was just 3 months. Now we have 9 months. And the feedback from the patients was that they actually appreciated the care manager contacts and what was mentioned before about the trustful relationship. One patient expressed his or her views that she very much appreciated that she had a contact person from the healthcare community in that way, that she could talk to at eyesight, she said. So there was, normally you would discuss the problems with your GP, but many, especially elderly patients, they have so much respect for doctors, they would not address their little worries. But the care manager in the escape intervention was a person that they trusted, and they could discuss their problems at eyesight and did not have the feeling they had to climb such a hierarchical step in that way.
Now, most patients really like this possibility to have a person who actively looks after them every once in a while by calling them. They don't need to go to the doctor, but the care manager calls in and asks how they are doing. And it's a great experience to have someone calling in and asking how you're doing and how you could improve your well-being, your medical health, your physical fitness, everything. And patients really appreciate that very much. And I fully agree that it must be a trusting relationship. In almost all cases, such a trusting relationship does develop and is one of the core factors in the success of the treatment.
Perfect. And what's our timeline on our clinical trial and our project? Christoph?
Well, the clinical trial started with the first screening of patients in April last year. And the overall project timeline ends in September 2025. And by then, the clinical trial should be completed. And we hope we will be able to complete it by then, because as in almost all trials, especially in that complex type of trial with 6 countries involved, there are always some delays with all the contracts and administrative issues. So the plan is to have at least the main outcome data available in the second half of 2025.
Perfect. Okay, so maybe looking to something a little bit bigger. Let's say we're super successful. This trial goes perfectly. So Susanna, what do some of the next steps look like?
Well, the next steps, if it's as successful as you mentioned, that would, of course, be implementation. And we have tried to be vigilant in terms of maybe discussing this well ahead of time. Although I have to be very honest and say, in terms of feasibility and getting it implemented, that I think that's a question nobody can answer at this point in time, because hospital systems across, I think, the globe, at least in Europe, they are really taxed, and there are so many other issues that they need to resolve. And also in terms of implementation, when we as researchers, make a project, I think some countries are favorable in terms of, I have heard it from the UK, if you get a grant from particular funding agencies, that means if it works, they will implement it. And that's not how it works, at least in Denmark. I don't know, Christoph, how it is in Germany, if you have a same luck as the UK people.
No, we unfortunately don't, but we are very well connected in the scientific community, of course, and also in the groups that are writing the practice guidelines. And once we get it into the guidelines, then we have very good arguments for the payers to pay for these treatments. And it's the approach we are choosing is very easy to implement over the whole country because it's scalable with centralized specialty teams, with care managers who don't need to be at the place where the patient is. Of course, it's always nice if the care manager can be directly affiliated with the GP office, but typically that will not be possible for most GP practices. So we can have centralized care managers, we have centralized care management teams, and the only thing that we need is reimbursement. And that depends, of course, on the fact that we can demonstrate it improves quality of life at a reasonable cost. And that's why we're also looking at the health economic aspects of the intervention. And if we can show that we are not too expensive or maybe even save money at a better result for patients, then the payers will be happy to pay for that.
Yeah. And one can hope, if I can just add to that, that other countries will follow suit in terms of what's possible in Germany. I also think that the advantage is that through ESCAPE, a lot has been developed in terms of the intervention and treatment manuals, etc., which also means that if it is successful, the ESCAPE intervention, then we can also say that it's evidence-based, which is quite important for implementation. So,
and maybe to our patient and care members here, again, say ESCAPE is very successful and we get the results that we're anticipating and hoping for. What is your role in supporting, let's say, the dissemination and the transfer, whether this is maybe to policy actors or to, healthcare implementation bodies? What does that look like for you, or is that a role that you take on? So maybe to Martin first.
Yeah, well, in Germany, we're part of the Federal Joint Committee, and the negotiations there, they are focused on evidence-based results of new treatment solutions. So we will support, of course, the idea if the study is successful, and this is a platform to discuss this, to discuss it with the practitioners and the payers, and so the discussions will go on. Well, we have to wait until we've got the results, but we will discuss it. And in addition to this, I just wanted to point out that for us, always it's important to support patient autonomy in the system, and this intervention is introducing a new situation, because we have the care manager and the patient as a couple of persons to work on the goals of the patients. And maybe it's a possibility to improve patient autonomy in the system. And therefore, and this is one of our main issues to change the treatments for the future.
Perfect. Thank you, Martin.
As far as we are concerned, we are very eager to see the results, and especially in the role of the care managers, which really help reduce the burden on informal carers. It also provides them peace of mind and allow time for respite care. So it has a great impact on the lives of informal carers, which is very important for us. And so we will take a really interested look at the results and see if we can replicate that in the future.
Perfect. Thank you, Olivier. Yeah, and I think it's important to mention we have here 1, 2, 3, 4, 5, 6 of ESCAPE's partners, but we are 16 partners in total. So we bring together a lot of different organizations with a lot of different expertise to help not only run the trial and the implementation, but then hopefully see it forward to the future?
Well, I have something to say. So we are still looking for patients interested in participating in our clinical study. This is very convenient because as everything happens over the phone or by mailed questionnaires that we're asking people to fill in, and there is a good chance to receive that innovative blended collaborative care intervention once you're a part of this study. So we cannot promise that everyone gets it because we have to randomize, not as randomly select 50% of patients who get the intervention. But even those who don't get it really make a great contribution to the progress of medical science. And so we invite everyone to look up the ESCAPE website and look for their nearest study site to contact them. So it can be from Ireland, from Denmark, from Germany, from Lithuania, from Hungary, and from Italy. So if you're interested, please visit our website.
Okay, thank you all so much for joining me today. I really appreciate you taking the time, and I hope everyone listening and watching was able to learn a lot more about the ESCAPE project, but then even more about blended collaborative care, patients organizations, care organizations, and so on. As Christoph mentioned, please take a look at our website. You can follow us on Twitter and LinkedIn and get in contact with any other questions you might have. Thank you so much, and bye-bye.